evening, everybody. I can already see there are 60 people online. We'll not get into the details as to what went wrong. So we are good to go. And thank you for being with us for this, what we are now trying to call the Friday 8 p.m. sessions. We hope to make this a regular event for coming for every Friday. And this is happening courtesy some of the requests from
Dr.
people who,
Shimantika.
people who are either appearing for exams or will appear for exams, as well as for routine people who are practicing anesthesia day in and day out. So some of the topics will be exclusively meant for postgraduate students, but they will always have a slant for use by the practicing anesthesiologist as well. Anyway, without getting into much of the nitty-gritties as was to what we intend to do in the future, let's talk about what we intend to do over the next maybe a year and a half. Okay, so what we will do is we'll have two kind of sessions tonight. One will be the myths about fasting and feeding prior to surgery, which will be taken by Dr. Shimontika Ghosh, and she is currently she also does anesthetized a few people who undergo general anesthetics here and there at Narayan Hridayalaya, but she is there to put to sleep or for providing anesthetic services for people undergoing the big transplants, liver transplants. Anyway, so she will be talking about fasting and feeding, and then I will take over and take you through a very, very generalized topic about the anesthesia perspectives of enhanced recovery after surgery, which is essentially a little bit about what the RAS thing is all about, but more about serving as a template as to how to address any anesthetic management for any kind of surgeries that are going to happen. So I won't waste further time, and I will hand over to Dr. Shimontika, take you through her presentation about the fasting and feeding during surgery. I hope, Shimontika, you are ready.
Yes, sir. Thank you for such a nice introduction. Okay, so good evening, everyone. I hope I'm audible to everyone. So the novel coronavirus, it has brought us to this novel platform where neither can I make eye contact with my audience, nor can I find out if I'm making them yawn. Nevertheless, I'm extremely grateful to my teacher, Dr. Shoikat Sengupta, for providing me this first-hand novel experience. And of course, the HCV Forum, represented by Ms. Joyati, for this opportunity. So tonight, I'm speaking on a very simple topic. But before that, I would request all of you to please mark your responses to the poll questions. There are just 3 of them. How long do your ASAPS1 and 2 patients fast for oral clear fluids when posted for an elective surgery? 2 hours, 4 hours, 6 hours, or more than 6 hours? Okay, so the next one, do your patients receive intravenous fluids when they are nil per oral? The answers would be yes or no. Okay, so we have the next question. When do you restart oral clear fluids for your uncomplicated post-surgical patients? 2 hours, 4 hours, 6 hours, or more than 6 hours? Okay. So done. Most of them have, I think, attempted this. So we move ahead. Hope all of you have answered the questions. Now, let's go back a little into history and find out where this all started, the concept of fasting. Way back in 1883, Lister noted down that while it is desirable that there should be no solid matter in the stomach when chloroform is administered, it will be found very salutary to give a cup of tea or beef tea about 2 hours previously. However, in 1946, Mendelssohn, the one who documented the Mendelssohn syndrome, he found that vomiting during labor and obstetric anesthesia led to respiratory distress due to pulmonary aspiration of gastric hydrochloric acid. And there started NBM from midnight. Again, 1986, Maltby et al. Giving patients a drink of water up to 3 hours before surgery did not increase the gastric volume or acidity of gastric contents. The first death usually attributed to pulmonary aspiration following anesthesia was recorded in a young girl way back in 1848 and apparently occurred when brandy was poured in her mouth to resuscitate her at the end of chloroform anesthesia. In Mendelssohn's classic paper that introduced the concept of acid aspiration syndrome, he reviewed the notes of around 44,000 pregnancies in which 66 patients developed pneumonitis. But interestingly, even in an era lacking intensive care, none of them died from this. The only two deaths that were found were due to upper airway obstruction from solid food pieces. So now, why do most hospitals ignore guidelines on fasting before surgery? Even literature reviews show that patients are not following the adequate guidelines. They are inappropriately being fasted prolonged. Well, thanks to the myths that fasting from midnight is the best way to reduce the risk of vomiting and pulmonary aspiration during anesthesia, that the gastric emptying time of clear fluids is same as other liquids such as milk and coffee, and clear fluids ingested 2 hours before surgery can increase the risk of vomiting and pulmonary aspiration. That there is no harm in keeping patients fasted from midnight, and changing the fasting guidelines will cause confusion among patients and lead to cancellation of scheduled operations. Well, are these myths or facts? Let's find out. Clear fluids, water, fruit juices without pulp, clear tea, black coffee, and any liquid through which a newspaper can be read easily. That is the standard definition. When given within 2 hours of surgery, it benefits patients by increasing their comfort, decreasing their incidence of perioperative dehydration, hypoglycemia, and vomiting. Yes, of course, intravenous fluids given during the fasting period can correct the deficit, but it does not relieve the patient's dry mouth and feeling of thirst. Overnight fasting has been shown to cause post-operative insulin resistance and immunodepression. The measurement of cardiac output and oxygen delivery in this era has allowed the recognition of the detrimental effects of dehydration and has also prompted clinicians to extrapolate that a patient arriving for surgery in a dehydrated state was not only detrimental to the patient's comfort and well-being, but also had undesirable physiological consequences, even if they were otherwise healthy. This has led to numerous studies demonstrating that free clear fluids could be safely administered until 2 hours before surgery in adults. The incidence of pulmonary aspiration has been found to be low, with morbidity and deaths very much lower. However, the fear of aspiration and the concept that the longer the fast, the safer it is for the patient has led to excessive preoperative food and fluid restriction. In the 1980s, they developed an appreciation that excessive fasting is not only unnecessary but also detrimental. Gastric pH, as well as the volume of the contents, is important in determining the severity of any pneumonitis. But don't forget that acid secretion continues even during fasting. For clinically significant pulmonary damage to occur, a critical volume and acidity of gastric acid must be aspirated. These were set at 25 ml, that is more than 0.4 ml per kg, and a pH of 2.5 by Roberts and Shirley. However, these results were derived only from the report findings in a single rhesus monkey. So further systematic animal experiments were taken, and they suggested a higher critical volume of 50 ml, 0.8 ml per kg. Very recently, a 1.5 ml per kg limit has been promoted based on a pragmatic evaluation of the prevalence of comparable gastric volumes in nil by mouth patients and the very low incidence of gastric aspiration. Increasing gastric pH is not possible by dilution of gastric contents with ingested water, but highly effective and reliable increases are possible by reducing the gastric acid secretion pharmacologically, as with the addition of H2 antagonists. Reduction of gastric volume, it has been seen that gastric emptying has an inverse relationship with the calorific content of the drinks consumed, with 330 kilocalories emptying slower than 220 kilocalories drinks, and water emptying the fastest. So there is an approximate exponential decline of stomach content volume with time, with water having a half-life of about 15 minutes, beef extract 20 minutes, and tea with milk 25 minutes. This very well suggests that a 1 hour fasting time for water is entirely reasonable. Maltby et al.'s classic study, which has been replicated by others, showed no increase in volume or pH with a drink of 150 ml water given between 120 minutes and 180 minutes before anesthesia. However, there are relative contraindications to this 1 hour fluid regimen, and they include gastroesophageal reflux either being treated or under investigation, renal failure, some enteropathies, esophageal strictures, achalasia, diabetes mellitus with gastroparesis, and or surgical contraindications. So what next? Is it enough that we give our patients clear fluid, water, just 2 hours before surgery? Would that suffice for a good perioperative outcome? Let's see. Cuthbertson's landmark studies, all of us have heard about it. He described the catabolic state that accompanies bed rest and major surgery, with the later work characterizing the stress response and resultant catabolism and hyperglycemia. Parallels have been drawn between the energy requirements for postoperative patients and for athletes undergoing a major sporting endeavor. Both require increased oxygen utilization. If this process fails, there is a switch to anaerobic metabolism and accumulation of lactate, with the outcomes for both patients and athletes significantly impaired. It was therefore understandable that high carbohydrate diets, well known to athletes, should be tried in patients undergoing major surgery. The standard definition of a carbohydrate load is at least 45 grams administered less than 4 hours before surgery. A commonly used formulation is a 50-gram sachet diluted to 400 ml to make a 12.5% drink. with an osmolality of 135, containing 200 calories. The key composition of oral carbohydrates is maltodextrin polysaccharides that are emptied reliably from the stomach after 2 hours. However, we again have a dilemma here. What about diabetic patients who are at risk of both disturbances in plasma glucose control as well as pulmonary aspiration if they have coexisting autonomic neuropathy? The paradox here is that the surgical stress response and insulin resistance will increase plasma glucose, which we know as the diabetes of injury, and should be reduced by carbohydrate loading. Yet, the same carbohydrate loading may substantially alleviate the plasma glucose levels. So what do we do? As we know, hyperglycemia is a key marker of perioperative outcome and causes increases in rates of infection, reoperation, and death. Yet when plasma glucose is controlled with insulin, there is no increase in the incidence of these adverse effects. However, though data is scarce, but we have one study which was performed in 25 patients with type 2 diabetes mellitus with no evidence of autonomic neuropathy. And in these patients, although the peak plasma glucose was higher in the diabetic patients than the non-diabetic controls, this feature was short-lived. So there's hope. Alternatives in diabetic patients are to administer carbohydrates as well as normal medication and or insulin, or consider the use of alternative drinks such as glycemic endothelial drink, which contains less of maltodextrin as well as citrulline, and which may lead to reduced gluconeogenesis. But we are anesthesiologists. We cannot change our practice just like that. We need objective evidence. So how do we get objective evidence? By measuring the gastric volume. So methods to assess gastric volume include nasogastric aspiration, isotope labeling, co-absorption of paracetamol, MRI, and ultrasound. Of all of these, only ultrasound is of clinical utility with a good correlation with isotope scintigraphy. It allows visualization of solid matter which needs to be treated as a high-risk full stomach even if there is a low content volume. The antral cross-sectional area is measured in the lateral decubitus position and the gastric fluid volume read from a validated table using a predetermined formula. Ultrasound assessment in children confirms that 10 to 15 ml per kg clear fluids given 2 hours preoperatively results in a reduction rather than an increase in antral volume by the time of induction. And according to a 2016 survey by the UK Association of Pediatric Anesthesiologists of Great Britain and Ireland, a number of pediatric anesthesia services have recently moved to a 1-hour rule for clear fluids. Many studies have shown us the effectiveness. There's an audit from India in which they found that the risk factor association has a greater effect on residual gastric volume than the hours of fasting, and that ultrasound assessment of preoperative gastric volume is an effective screening tool in patients with risk factors such as GERD, obesity, diabetes mellitus, and chronic kidney disease. A recent study just published in April 2020 for assessment of gastric content in fasted patients before elective lab choles. There are many guidelines that have been coming for the fasting guidelines and the feeding of patients perioperatively. Most of them concur. The American Society of Anesthesiologists published guidelines in 1999, 2010, and then updated it in 2017. The fasting recommendations by ASA, they recommend a minimum fasting period of 2 hours for clear liquids, 4 hours for breast milk, 6 hours for infant formula and non-human milk, human milk and light meal, whereas more than 8 hours for fried foods, fatty foods, or meat. Not only preoperative fasting, but perioperative feeding is equally important. When you resume your patient's feeds post-surgery, also affects outcome. So the SPEN guidelines were a very good set of guidelines published in 2017 targeting the clinical nutrition in surgery. In 2019, the NICE guidelines were updated and have the same recommendations more or less as SPEN. But all of these are international guidelines directed at a population which is totally different from our population. The data that they have is only from the Western population. What about the Indian population? So the time has come for our guidelines made by us for us. Just this month, the Indian Society of Anesthesiologists has come up for the first time with perioperative fasting and feeding in adults, obstetric, pediatric, and bariatric population, a set of practice guidelines from the Indian Society of Anesthesiologists. Well, if you ask me, what was the need? Well, diverse healthcare settings and differing practice standards from Kashmir to Kanyakumari. Patient population varies in terms of food items consumed with a variable fat content, caloric content, and nutrient composition. The socio-cultural, geographic, and economic factors also play a role in the food habits. The available international guidelines do not apply uniformly across the SAARC countries, and very few evidence addresses the problems that are peculiar to this region. These guidelines focus on recommendations for withholding solid and liquid food before elective diagnostic or surgical procedures performed under deep sedation or anesthesia, be it regional or general. For the resumption of oral feeds in the post-procedure period, aimed to reduce the incidence and severity of aspiration pneumonitis and other complications such as hypotension during induction of anesthesia, to prevent delays or cancellations of surgical procedures, and of course, all of it for a better patient outcome. There are a few definitions that have been devised in these guidelines. They define an empty stomach as a state when the gastric contents reach the baseline volume after the intake of a solid, semi-solid, or liquid meal. Baseline volume is defined as the volume of gastric contents of an adult after overnight fasting. Residual gastric volume is the volume of gastric contents at the time of examination or evaluation. A full stomach is the presence of solid content or a state of increased volume of the liquid gastric contents above the baseline volumes after the intake of a solid, semi-solid, or liquid meal. Here, they have defined clear liquid as any liquid which takes less than 2 hours to empty from the stomach in human beings. A non-clear liquid is defined as any liquid which takes between 2 hours and 4 hours to empty from the stomach in human beings. A light meal is defined as any food item which takes between 4 hours to 6 hours to empty from the stomach in human beings, and a heavy meal is any food item which takes more than 6 hours to empty from the stomach in human beings. Now, clear fluids like coconut water, they have even specified the amount: 400 ml of coconut water, 200 ml of black tea, 200 ml of black coffee, 25% dextrose, watermelon juice, juices without pulp, that is. They can be taken within 2 hours of surgery. Non-clear fluid liquids like 200 ml of milk, buttermilk 300 ml, fruit yogurt 150 ml, cold coffee 200 ml can be taken 2 to 4 hours before surgery. A light meal can be taken up to 4 to 6 hours from induction of anesthesia, and a heavy meal needs to be taken at least more than 6 hours before anesthesia. Now, as per the recommendations, a strong recommendation for adults that clear liquids should be allowed up to 2 hours prior to administration of sedation or anesthesia. Strong recommendation that a heavy meal consumption is not advisable the night prior to surgery. Again, a strong recommendation that routine use of aspiration prophylaxis in adequately fasted patients is not advisable prior to administration of sedation or anesthesia. Coming to the obstetric population, heavy meal consumption is not advisable the night prior to surgery, and pregnant women requiring sedation or anesthesia should be administered aspiration prophylaxis. Clear liquids can be allowed orally 8 hours after cesarean section under regional or general anesthesia. Consumption of water up to 3 ml per kg should be allowed until 1 hour prior to administration of anesthesia in the pediatric population. And the oral consumption of clear fluids in the postoperative period should be resumed at the earliest where no medical or surgical contraindications exist in the pediatric population. Not many changes in the bariatric population guidelines, because it's a weak recommendation according to them that obese individuals may be considered to be at higher risk for aspiration compared to non-obese individuals when administered sedation or general anesthesia. And in obese individuals, the advice on preoperative fasting practices may be the same as in non-obese individuals prior to administration of sedation or anesthesia is also a weak recommendation. Coming to gastric ultrasound, the quality and quantity of gastric contents should be assessed in the right lateral decubitus position, has a strong recommendation in these guidelines. So now we have our own guidelines, and probably because this is the new set of guidelines, we need to probably go through them, and there may be additions and changes coming over the years. But yes, good that at least there has been a start. So that's all from me. Thank you very much.
Okay, thank you, Shumantika.
Thank you, sir.
Am I audible? Okay, I think people, not many questions as yet. I think too early in the evening, possibly. Dr. Apurva is asking, what is the definition of the carbohydrate load that you mentioned? She possibly missed it in the slides.
Okay.
And to everybody, even if you have missed it in the slides, I think these presentations will be uploaded and will be available on the HCP forum, and they have put it as the web-based lecture anesthesia series. So since you have registered, since you are watching this and hearing this, at the end of the session, maybe within 24 hours, these are uploaded onto the HCP forum. So please feel free to go to the website and follow the link, and you can, if you have missed anything, you can see it there. It's good to find. Yeah, you carry on, you figure it out. Dr. Chakrarao, thank you for joining us, and I can see one of my gurus of pediatric anesthesia, Dr. Ramesh, has joined in. Thank you, Dr. Ramesh, for coming in. It's so heartening and so warm to have all of you around.
So Apurva, the standard definition of a carbohydrate load goes as at least 45 grams of carbohydrate administered less than 4 hours before surgery. 45 grams less than 4 hours before surgery.
Okay. If anybody wants to possibly add something, I think I can see Bibu madam is there. she wanted to put in something. Professor Amna Goswami, she wanted to say something possibly, or Shuchodita wanted to say something. Okay, till that time, Shimantika, there is a question from Dr. Dilip, and Dilip has been one of the instigators for starting this lecture series. Dilip wants to know whether there is any recommendations for total parenteral nutrition post-operatively.
Okay, thank you for the question. Uh, TPN mostly for patients who are not able to take orally, or maybe probably they'll be because of the surgical complications. We are not able to start the fluids, but the best thing to be done is to start orally. That will prevent even gastric translocation and help the gut to recover soon. So TPN recommendations are just for a very limited set of patients.
Yes, I think what I would add to Dr. Shimuntika is that unless there is a reason not to feed the gut, you feed the gut as quickly as you can. And this is something that we learned from critical care, and which is she was talking about one of those things about fast hug, where you start feeding the gut as quickly as you can. So unless there is a pressing reason of not feeding the gut, you start feeding the gut. And I think I will take you through the ERAS things. And one of the few things that we learned from ERAS was that that block in the mind, and this is a typical surgical block. I think it's more with the surgeons, that if there is a GI anastomosis, they would withhold feeding the gut till, I would say, time immemorial. But now we have got data even after an esophagectomy that people have fed the gut in the PACU and then send the person to the ward from the PACU. So all these myths about when to feed the gut is slowly going away. And unless there is a pressing need, you don't actually go on to TPN uh, in the post-operative period. Uh, Shimuntika, there's a question from Dr. Shomodik Pal. At
Yes.
what time would you recommend the post-cardiac and neurosurgery patients to be started on feed?
Well, post cardiac patients, again, what is the status of the patient, and post neurosurgical, about the GCS status of the patient. The overall recommendations are to restart the feeds, as Sir rightly mentioned just now, that it's overall the recommendation is to start as soon as possible, because that helps prevent a lot more complications, which then take the patient to a vicious cycle. So I haven't come across literature which focuses on patients undergoing cardiac or neurosurgery, but I think even in those patients, it is wise to start feeds as soon as possible. Obviously, taking into account their neurological status in the patients for after neurosurgery, and hemodynamical instabilities in post cardiac surgery patients.
Yeah, I would just add that it is, if you're fast tracking, even after cardiac surgery or neurosurgery, as is the norm, I think the standard protocols should be followed. If they're good to be extubated, if the hemodynamic is still stable, and there should be no reason why we withhold fasting. I think Dr. Aditya Gupta has a question for you on the mandatory glucose drink pre-op, especially in the Indian scenario.
Yeah, mandatory. We can't. I don't think we should term it mandatory. Yes, but I know of quite a few institutions which are following the ERAS protocol, and they are giving preoperative oral carbohydrate loading uh, before not only major surgeries, but I also know of institutions where they are giving oral carbohydrate loading before endoscopies. because that has been shown to have better peri-procedural or peri-operative outcome. There are also institutes which are using not only if I mean a few years back when oral carbohydrate solutions were not so available, they were also using some glucose drinks, and a few institutes I know were using Apifizz uh, 2 hours before surgery. So it is being done in India. Yes, it is being. I know institutes which are doing.
Yeah, I think I can tell you what as to what we used to do, and we still do it, and I find it pretty effective. Is just have that 25% dextrose, 25 ml, those ampules. You break two of them and give it in a glass of water and let them have it. It's good enough. If you don't have anything, I am a little skeptical about the fizzy drinks because I think I would not be happy to have them having a carbonated drink. And I think Shimantika, Dr. Amna Goswami wants, Madam, it's lovely to have you. So nice to have all of you with us. Amna Madam wants to know what exactly would you define by a clear fluid?
Okay, ma'am, thank you for joining. And reading a newspaper through the fluid, actually, that was the definition that was taught to me by Rudra sir when I joined anesthesia. That was the definition of clear fluid that I was taught. But yes, now the latest guidelines by the ISA, according to them, they have defined clear fluid as a fluid which is emptied, which has a gastric emptying time less than 2 hours.
Okay. Uh, I think Dr. Nilobroto Ghosh wanted to know, is it recommended or is it possible to administer sodium citrate as an anti-aspiration prophylaxis in our setting?
Well,
I think Nilob,
I have no, I in all these years, I have no experience of administering sodium citrate.
I think I'll tell you about this, Nilobroto. I think we did have sodium citrate for a few years, but I think it was not used and the manufacturers took it away. So we don't get those pre-filled sodium citrate 20 ml kind of small bottles that we can get and which is available freely in the West. So we don't get it here. But if it is available, you might use it. Now people can question as to what actually would you really need it. But yes, if it is a high risk patient with an acid aspiration, for acid aspiration prophylaxis, those who are at high risk of acid aspiration, it may not be a bad idea to use it if you have it. Okay. Shomodi Pal wanted to know what is the recommended fasting for patients undergoing procedures like percutaneous interventions, chemoport insertions, and stuffs undergoing regional blocks.
Shomodi, I think the recommendations are the same because you see, even patients undergoing procedures under local anesthesia, they can anytime need to be converted to a general anesthetic. So the recommendations, the guidelines remain the same.
Yeah, I think that is true, and that should be the take-home message. Dr. Abu Riaz, good to have you, Abu, from Guwahati. Patient on RT feed, is the patient allowed clear fluids 2 hours prior to surgery?
Well, we need to withhold the rice tube feeding uh, more. If we are feeding the patient, obviously the feeding should stop. But clear fluids, yes, I guess at least for to prevent his uh, the thirst and the not the feeling of thirst. So he can be at least allowed to at least wet his mouth. I am not sure of a specific guideline per se.
Yeah, if it is on a RT feed, through the RT, yes, you can. As long as it's the same clear fluid that you have given through mouth. Okay, I think there are no more questions for you, Shimuntika, and then if everything is fine, if my slides are good to go, Jyoti, we put them up. And yeah, thank you very much, Shimontika, for that excellent presentation, and
Thank you very
for clearing the doubts of many. I hope I'm audible. Uh,
much.
and I will take you through, as I said, the enhanced recovery after surgery, the anesthetic management. And what I will try and take you through is try and get you a kind of a template as to what you can use, especially for students, when you are trying to get in for, you face any question that you get as to anesthetic management of a patient undergoing X surgery, Y procedure, or D operation. So I think this serves as a very good template. So what essentially is this ERAS? And ERAS has come as a question. It is asked during practicals. It is asked in theory. So what exactly is ERAS? Is nothing but enhanced recovery after surgery. Some people also call it the enhanced recovery pathways. And this came out with a publication from Kellett in 2008, which essentially is nothing but multimodal, multidisciplinary fast track surgery. Uh, right now, we kind of associate this with things which can fasten recovery after various type of surgical procedures. And these protocols that you have are evidence-based therapeutic interventions, and this starts in the preoperative period and goes on till the postoperative period. And you'll find a lot of these protocols and guidelines which come in, and these keep evolving. And so the last that I could go through were ones that were published in 2019. And a good friend of mine, Dr. Girish Joshi, sitting in Texas, has been one of the key proponents of these ERAS pathways. So what does ERAS or ERP try to do? It is they're trying to do a standardized care, and this standardized care can be taken over through all institutions, so that we then know, if you go get them through these protocol, that do you actually improve the outcomes. They take into account that the surgery is a huge kind of an insult to the patient's physiology. So there is a huge surgical stress response, there is post-operative pain, and if you can manage these two effectively, you can reduce complication and improve the outcomes, and which essentially leads to decreasing the hospital length of stay and expedite the recovery following a lot of elective procedures. So this is the ethos of ERAS. Uh, is ERAS anything different than what we used to do 10 years back, 15 years back, 20 years back? It essentially is not. And this is what we keep telling people, that the principles of perioperative care for major surgical procedures, particularly the preoperative and intraoperative management, remains the same. It's only that few things have been brought into limelight. Some things have been highlighted. Some things have been figured out, that which was done routinely, kind of without much of evidence, is not been doing good to patients, and it's time to abandon that. And there are certain things that you do for certain procedures. So there are few procedure specific variations. What we will go through today is not very procedure specific, but a very generic one. uh, this is how the ERAS, I think, I came out, I talked about in the early 90s that it came out, and they had a huge number of elements that were part of the protocol. Till it's around 2001, they figured out that not all of these are equally weighted, and there is not enough evidence to suggest that they improve post-operative recovery and decrease complications. So the ERAS elements, and these keep changing. And the one that I could find in 2018 were, I think, few of these that I have just put in, and we will go through this as we go through the evening. One is no mechanical bowel preparation. I know that as an anesthetist, we are not much involved with this, but it is one of the elements, in a huge element. I think we talked about myths about feeding and fasting. And this is what we learned from ERAS, that you allow a light meal up to 6 hours and consume clear fluids, including the much talked about oral carbohydrate drink until 2 hours prior to the initiation of anesthesia. Pre-medications, and this is, I think, a huge area that I have learned from ERAS after following ERAS, is that pre-medications is not the classic pre-medications that we learned in our residency days, but this pre-medications would be uh, pain medications, and classically the non-steroidal drugs, acetaminophen, NSAIDs prior to surgery, and possibly antiemetics that you start prior to surgery. Intraoperatively, maintenance of normothermia, euvolemia, which I think intuitively everybody does. Again, a huge surgical thing. Don't put in tubes and drains if you don't need to. So avoidance of surgical drains and nasogastric tubes. And this is a collaborative effort that you do along with your surgical team. Infiltration of the wound with local anesthetics. And I think as we have evolved over the last couple of decades, we figured out what is the best plane also to infiltrate this local anesthetics. We'll go through that. Huge focus has been on post-operative nausea, vomiting, because it's a huge indicator for recovery in the post-operative period, and the use of antiemetics. Early introduction of solid diet, and I think we had questions in the previous session on this. Multimodal narcotic sparing, and I think opiate has become a bad boy in the books of many. And so ERAS has tried to focus on sparing narcotics. IV fluids, try to get the patients off IV fluids as quickly as you can. If you can fit the gut, if they can tolerate feeds, something like 600 mils, lock the IV fluid, remove the drains, remove the catheters as early as you can, active mobilization. And back to what we can do is optimization of comorbid conditions pre-op. Huge focus on antibiotic prophylaxis. Most of you would do this intuitively. This is again coming into focus, venous thromboembolism prophylaxis, and this we realize that even the Indian population is very vulnerable and susceptible. We used to think that it happens only in the West. It does not. It happens to us as well. And lung protective ventilation. These elements are the ones that we'll go through over the next few moments. The stakeholders are just not the anesthetist. The patient is the primary focus, and it's also the surgical team which needs to be in. You have to involve your nursing staff, and essentially the institution has to be focused about ERAS to make it successful, because there are multiple facets from the pre-operative period, during the surgery, and in the post-operative, and unless everybody speaks the same language, you don't get to the desired effect. The journey, as I said, starts from the time the surgeon sees and decides that this patient needs surgery till the time they go home. We as anesthetists possibly are more focused at the intraoperative phase. So the preoperative considerations, I think this again is a no-brainer, that you optimize the patient's preoperative conditions, which can have a bearing on the postoperative outcomes. Coming to this again and again, minimizing the fasting period, maintaining the hydration during the fasting period. This is again is a huge game about communication. So this patient and family education and pre-medication. So comorbidities, not only do you look at the functional status, medical history review, medical reconciliation, what we learned from ERAS essentially is that we not only identify the cardiac and pulmonary risk, and this is, if you ask me personally, this is something that over the last 10, 15 years that I learned, that you look at the person's age, frailty, that this is the Gestalt law again. If the person looks frail, does not look good to you pre-op, be aware that may not do very well in the post-op. So keep this in mind. Things like, did they have history of falls? Again, this is related to functional status, but I think this is things that ERAS can has actually taught me. And we used to not take cognizance of the cognitive function of a patient. So figure out, are they kind of mentally alert and with you, and that will also kind of determine how well they would do after the surgery. So this is something that eras has focused on. I think this we have gone through. I will not take you again through this. And with what you're essentially trying to do is go from the fasted to the fed state. And why are you doing this is, I think, that you're reducing the post-operative insulin resistance and the post-operative weight loss. And so you're trying to keep them as fed up as you can. So pardon the pun on that. So I think Chimontika took you through this. You gave, as some people have recommended, I would be a little skeptical to do this, but I would be happy with a glass of water, which is around 500 mils containing 50 grams of carbohydrate, but you can go up to that. And this is shown to have improved the glycemic control, but not necessarily about the infection control. I think this is important. PFE, this again, most people would do intuitively. You talk with the person, you talk with the person's friends, relatives, try to reduce the anxiety, tell them, get them on board as to what their expectations are. Tell them about what your pain control management is going to be. If you're going to use something like a PCA pump, this is the right time to talk about it and get them on board. So if they are on board with you, I think the stuff becomes much easier. It's always good to have this kind of a new name to it. Uh, we have heard about rehabilitation, and ERAS gave me a new term called prehabilitation, and they came with this new prehabilitation program. So new is an acronym. N stands for nutritional supplementation, E is for exercise programs, and W is for worry and anxiety, which essentially is stress reduction. And you do this to improve the cognitive functions as well. And it also takes the rehabilitation, talks about smoking cessation. And why I tell this is a good template, so you can figure out that you can use this template to answer or to deal with any particular clinical scenario. Nutritional supplementation is again, it's because this surgically you develop this huge stress response. So you give them this load so that it mobilizes carbohydrate, lipid, and protein stores that are done during a surgical stress response is kind of optimized. And you are trying to do also work on is that to see that there is not a malnourished person who gets in. And people have figured out that there is evidence that a whey protein supplementation without exercise for colorectal surgeries, and you'll find a huge amount of data for ERAS procedures coming from colorectal surgeries, that it has decreased length of stay. This is a good algorithm to follow, and looks at the preoperative nutrition score. You look at things like the BMI. Is the BMI less than 20? I think is a good benchmark. Is there an unplanned weight loss which has happened in the last 6 months? And are these patients eating less? If the answer to them is yes, and if you find that the albumin level is less than 3, then it might be prudent to optimize this person's nutritional status before you take this up for an elective major surgery, especially major surgery. There would be people who would say that, do I have the time, especially if it is a major oncological procedure? I think if you look at the current data, waiting for 2 weeks to 4 weeks may not will not influence outcomes. And I think the COVID pandemic has also taught us this, that even in the so-called high acuity surgeries can be pushed to the intermediate acuity. So it might be prudent to improve the nutritional status. What has been shown to be hugely beneficial is this physical exercise programs prior to major elective surgery. And this whole business, again, I think sports teaches us a lot of things, and this has been something which has been taken directly from sports physiology. As if they are exercising well, they will be delivering more oxygen to the tissues. And if they deliver more oxygen, you will have less of tissues which are hypoxic, and these people will do better. How can you do that? I think I personally think that if you take them through the CPET, if you can't have CPET, just take them to the 6-minute shuffle walk test. See how they are doing. If they're doing okay, ask them that whatever you did today till the day you do the get come into the hospital for your surgery, keep doing this once or twice or thrice every day at home before you come into the hospital. If they're not doing it well, it is possibly prudent to figure out, is there a correctable cause which I can correct prior to surgery? If there you cannot figure out a correctable cause, then you ask them to do it possibly more so that their exercise tolerance improves. And this can have a huge bearing in the post-operative outcomes. So physical exercise programs can be very, very important. And work stress reduction is about the behavioral instructions that you give, pain instructions that you give, allay their anxiety. And this, if you can reduce this, the surgical stress response can be reduced. And there are now evidence, you can find studies which have figured out that the post-operatives indicators of stress response, like the serum cortisol levels, the urinary cortisol levels, the serum metanephrine levels, and the urinary metanephrine levels are low in people who have been given a good PFE. I think these are again about delirium and about things, procedures like an acupuncture prior to spine surgeries, which have improved outcomes. Smoking cessation, and this is, I think, a very, very kind of favorite questions for people who set theory exams, as well as people who ask any a student coming in for an examination for a person who is a smoker. So when do you ask them to stop smoking? If they can stop smoking for a year, you get the maximum cardiovascular and pulmonary effects. Even if you can stop them for 4 weeks to 8 weeks prior to surgery, the major pulmonary complications have been low. But even if you can stop them for 48 hours, there is some benefit, like decreased carbohymoxemia levels, elimination of the nicotine effects, as well as improved mucociliary clearance. Okay, coming to pre-medication, and this is where there has been a paradigm shift, before, for me at least, before and after ERAS. One of them has been to avoid anticholinergics, which I think was a kind of a slam dunk routine for all of us, and to avoid benzodiazepines. There is enough evidence. I will not bore you through that, as to how, if you have people who have not been given benzodiazepines have woken up faster, have stayed lesser period of time in the PACU, and also have possibly stayed lesser amount of time in the hospital. Anticholinergics, if they have not been given, their pulmonary clearances, the pulmonary complications have been lower than those who have been given. The pre-medications that people have looked at is oral paracetamol 1 gram 2 hours prior to surgery, along with it a COX-2 specific inhibitor like celecoxib 400 milligrams 2 hours pre-op. In our institution, what we follow is the oral paracetamol one. And if you think that there could be a likelihood of persistent post-operative pain, classical examples being spine surgery, knee arthroplasty, it's possibly a good idea to have them on either pregabalin or gabapentin 2 hours prior to post-op. Some people have shown benefit if they have been started even 2 weeks prior to surgery. This is something which is not very easily followed. Most surgeons will not let you do it. They won't start it as subcutaneous heparin pre-operatively. But what we have routinely done is essentially, if you think that there is a high level of venous thromboembolic phenomena happening, oncosurgery, then bilateral sequential compression device, they come into the theater with a SCD on them. This is something that I think I picked up before I was making this presentation, is a drug called alvimopan, which is a PAMR, which is a peripherally acting mu-opioid receptor antagonist, which has reduced prolonged ileus in bowel and gynecological surgery. And especially if you think that you are going to use narcotics in the post-operative period, you can start them in the preoperative period. I don't know whether it is available with us. This is of theoretical interest. What do you do in the intraoperative period? One is antibiotic prophylaxis. So when do you give antibiotics? It is 30 to 60 minutes IV before the surgical incision, because this is when you will find that the MIC of most of your antibiotics is the highest, and this is when you need the antibiotic to get in. And to time it, I think the easiest to do it is immediately after induction of anesthesia, you give this IV antibiotic. If the prophylactic antibiotic is something like vancomycin or fluoroquinolones, then they need to be started much earlier, maybe a couple of hours earlier, because you need to give them on an infusion, and they should be on board before the surgical incision. Do we need to do repeat dosing? Yes, if the procedure exceeds 2 half-lives of the drugs, you give it, or if there is an excessive blood loss, more than 1.5 liters, you repeat it. If there is renal insufficiency, you may not repeat it despite the above two. How do you provide anesthesia? I think it is the same. I think there is nothing, any difference. Propofol with lignocaine, fentanyl, intermediate acting muscle relaxant, which all of you would do. If there is a high risk of pulmonary aspiration or difficulty, I would think of suxamethonium. Beware of hypotension, and do not be shy or ashamed to use vasopressors if you do get that. Maintenance, I think you can use either inhalation or Retiva. Both are equally acceptable. I think all of us today would do short-acting agents at the lowest possible doses. Lowest possible doses is something that they talk about because of the residual effects of inhalation anesthetics and IV hypnotic and sedatives, opiates, etc., and muscle relaxants, which can delay recovery or result in other adverse events. The goals of emergence is a rapid, clear-headed awakening with adequate analgesia. How do you maintain? That is a potent inhalation agent with nitrous oxide. And I think ERAS has been responsible for getting nitrous back in our popularity scale. Nitrous went out, and it became something not to be touched at, as kind of an untouchable. But I think nitrous, to me at least, makes a huge sense to use unless there is a pressing need not to use it. You target a MAC value of around 0.8 to 1, so that you neither give too much of an anesthetic, and at the same time you ensure that it is just enough so that they are not aware. Why volatile instead of intravenous? I think there are many reasons, and most of you would know it. It gives you obviously some muscle relaxation, but to me it is the ease of titration. And even if you do not have a neuromonitoring ability to look at BIS and avoid DEEF levels, you can look at the end-tidal concentration of the gases, and if you have an idea about what an ETAC leads to a MAC of 1.7 or 0.8, then you try and titrate your dialed concentration in such a way, along with your fresh gas flow, that you achieve these end-tidal anesthetic concentration. This is, I think, for industry. And possibly when I get a particular sponsor, which is why this slide is blank, that I will talk either in favor of desflurane or in favor of sevoflurane, depending upon who pays me more. But since nobody is doing that, no conflicts of interest, to me, it is up to you and what kind of a patient and what kind of a procedure you are doing. Both are equally good. Uh, I think this is obviously from Benjamin Button, the curious case of nitrous oxide. I would still routinely use nitrous, not only for its amnestic and analgesic properties, but because it facilitates uptake and removal of the potent volatile agents because of the second gas effects, I can have the ability to rapidly change the anesthetic depth as well as in the emergence. So I would still continue to use nitrous, and this is the ERA's backing as well. People have said that yes, nitrous increases the risk of PONV. I agree, but if you're using prophylactic antiemetics, the risk is no less or no greater than if you are not using nitrous. uh, Distension of closed spaces, yes, that's an issue. I may not use it, but if there has been very beautiful publications on this as to how bad is this bowel distension, and people have asked surgeons to tell you later on that did they feel that I have used nitrous or not, and believe it or not, they could not. So if you want to go one up on your surgeon, you can try this for the next few months as to whether they could figure out whether you have used nitrous or not. The Enigma 2 trial has, I think, buried a lot of myths about the adverse cardiovascular effects of nitrous, to say that it is pretty safe and it's good enough to use nitrous. And this meta-analysis or a narrative review on the role of nitrous, and if you look at it, you find that all these things are the major adverse events of nitrous. Either they happen, things which have a good evidence level, they happen very, very infrequently. And things about even the environment that you talk about, atmospheric pollution, occupational air pollutions, are possibly not as important as many people drum it about. Can we use a TIVA technique? Yes, you can in selected patients, but whether TIVA actually decreases the incidence of PONV, the data is inconsistent. And now what we have got from this meta-analysis published by Schaefer is that it says that if you use inhalations with one antiemetic, the benefit of using a TIVA is marginalized. So there is no added advantage of TIVA if you use antiemetic. Typical TIVA is run with propofol, and I think it is not a great idea to do a complete TIVA technique unless you are doing some neuromonitoring with BIS, because you will not be able to figure out whether they are completely, whether they are at least not aware or not. Most of us in India would not have much of an idea about how to use remifentanil till it is used, but a typical TIVA technique would use remifentanil along with propofol, or many would use just remifentanil alone. This is something that I think people have been talking about in the last few years. Are opioids the new outcast of this anesthetic armamentarium? And it increases the opioid related adverse events. We know about it. It has the potential for doing things which we thought they are doing good, including the paradoxical increases in post-operative pain and opiate dosing requirements if you use them in the intraoperative period. What is possibly suggested is avoid the high doses. Try and see if you can have an opioid sparing approach. And if you need to, use only small doses of opioid and use them at intermittent levels. And this, I think, makes a lot of sense. Limit the dose of something like fentanyl to less than around 1 microgram per kg per hour in the intraoperative phase, and do not use it, because opioids are not the only answer to hemodynamic changes. Because intraoperative, this is, I think, classically, the heart rate goes up, you give fentanyl. The blood pressure goes up, you give fentanyl. So if you're using fentanyl to greater than 1 microgram per kg per hour, then think about other things. Think about beta blockers, think about vasodilators, because is it happening due to an increased intra-abdominal pressure? Is it happening due to an absorption of carbon dioxide, the surgical procedures? How will the use of opioids help in changing the hemodynamic status in these scenarios. So this is what you possibly can think before you next time pick up this syringe of fentanyl and start giving it. A lot of focus intraoperatively has been on neuromuscular blocking agents. So what does it say? I think this is again something which most would do kind of intuitively, that you avoid profound muscle paralysis. Your target is not a train of 4 count of 0. You would be happy with a train of 4 count of around 2 to 3. And if you can do it with intermediate or short acting neuromuscular blocking agents, and I don't know, I think if you could have run a poll here as to how many of you still use pancuronium, we would have got an idea on this. But anyway, so this is about neuromuscular blocking agents. If you can, it is always a good idea to have objective neuromuscular monitoring whenever you can. And this is again something that I picked up from the ERAS protocols is, do we give the same amount of reversal of the same agent irrespective of what is the neuromuscular status at the end of surgery when you're giving a reversal agent? Uh, this is a straight lift from one of the textbooks of anesthesia. What do you want to do is, if you're having a neuromuscular monitoring, you look at the adductor pollicis, and if you're looking at it, you have a train of 4 count of 1 to 2, that is sufficient, unless it is something like microscopic surgery that is happening, unless if it is something like a neurosurgery, you don't want any movement like an aneurysm clipping. It is then that you look at a PTC of 0, that is your target. Otherwise, a train of 4 count of 1 to 2 is good enough to go. Same thing about recovery, and this is something that I think I picked up a lot from the ERAS protocols. We do not have Sugammadex as yet, so I won't comment about what is happening in the first 4 or 5 columns. It's a busy slide. But again, if you have a train of 4, visual or tactile, this is where you would then start using neostigmine. If it is without fade, then obviously the amount of neostigmine that you want to use would be lower, and if it is with fade, obviously it would be higher. And this is something that again, you need not be very brave if you already have a neuromuscular monitoring which is good. So if you see that there is no fade to just a switch, you might also decide that you may not give a neuromuscular reversal agent. If you get a train of 4 ratio, which is 0.9, which is what is the criteria for extubation, then yes, you may not possibly have to decide on giving neostigmine. So this is something, it's not that I would do on a routine basis, but yes, I have done it occasionally and with good results. So no reversal agents if you have demonstrated train of 4 ratio of 0.9, and you give neostigmine only if you see a train of 4 count of 4, and you give the reversal agent. This is about Sugammadex. If it is available, then people now they say that if you talk to your friends in the West who have this access to Sugammadex, they say that, why do you want to do neuromuscular monitoring? Because whatever is the ratio, whatever is the count, I don't give a damn, because I have Sugammadex, I'll give it, and the patient will wake up, or there will be recovery. So till then, I think it is prudent to use these, follow these recommendations. And if you do not have this, I think one of the good things to do is administer neostigmine. People say wait for 10 minutes. It might be difficult to wait for 10 minutes, but wait for a sufficient period of time. Go by your clinical acumen, by your clinical judgment, and then extubate the trachea. Because residual or incomplete neuromuscular blockage has huge repercussions, and this is, I think, everybody knows about it. This is again something which is coming in a huge way, and that is about lung protective mechanical ventilation and what to do about it. So you have Low tidal volumes. This is again something that has happened with patients in the ICU, especially ARDS, and you just carry on what you learned from there. Give PEEP to everybody whom you anesthetize, and especially for certain procedures like lap, obese patients, tip Trendelenburg, give a higher PEEP. What you need to monitor, see that your plateau pressures are less than 16 and your driving pressure, which is nothing but the difference between the plateau and the PEEP, is less than 16. It will not lead to barotrauma, volutrauma, or even atelectative trauma. Your FiO2s, keep it low as around 0.4. Some people would now recommend 0.3, but I would keep it at 0.4. This is a little counterintuitive to many, is what should be the respiratory rate. Many are recommending that you even go lower than 12, lower than 10, go up to nearly 8. Let your ETCO2 build up, approximately 40, 45. A higher PCO2 or a higher carbon dioxide might actually be beneficial because it increases cardiac output by vasodilatation, and it also shifts the oxygen dissociation curve to the right. So you might be happy to have a higher CO2. I am waiting for evidence on this. I would still keep it at around 12. This again makes a huge sense. Recruitment maneuvers, especially if you think there's an issue with oxygenation, like in obese patients or in certain specific procedures like laparoscopy with the steep tilts, or if there has been disconnection. So recruitment maneuvers can be done. What happens when this strategies fails and you have a scenario of hypoxia, hypercarbia, high airway pressures? High airway pressures above 50, if you have the ability to have pressure control with volume guarantee, go to that. Otherwise, it's not a bad idea to change the IE ratio from 1:2 to 1:1 to offset this high airway pressures. Hypoxia with a saturation of less than 90, I think, again, intuitive. Rule out external factors like kinks, etc., disconnections, auscultation, breath sounds, endobronchial intubation, and other. After that, you can increase the FiO2 and do the recruitment maneuvers. After the recruitment maneuvers, settle at a little higher PEEP than what you were initially at. Hypoxemia, high airway peak pressures persist. I think especially this would be in patients with positioning problems like Trendelenburg. You can think of reducing the degree of tilt or reducing in laparoscopic procedures the insufflating pressures, get it down to 12 or 10. And if it's an open procedure, is that the retractor or a mop which is pushing the diaphragm up, which is causing this? So think about that. Hypercarbia, ETCO2 going up, unless the other reasons are ruled out, obviously start hyperventilating. Examine for signs of subcutaneous emphysema. And if it is still persisting, and if it's a lap procedure that has happened, discuss it with your surgeon and you might think of converting. So from ventilatory management, I think let's come down to fluid management, which is again something that has changed a little bit over the last few years or decades. The goal is obviously maintaining tissue perfusion and restoring or maintaining euvolemia with zero balance fluid therapy. And what is your go-to fluid is a balanced salt solution, and you give it at 3 ml per kg per hour. What you do not, and this is something that we were taught in our residency days, but we do not do it now, is preload fluid prior to a block or induction of GA. And you kind of do not replace each and everything that is lost: urine output, insensible loss, and this so-called third space losses. Go-to fluid is a balanced salt solution instead of normal saline or colloid. If you're losing blood, crystalloid 1.5 times, colloid, if at all you want to use it, do not use it. That is my recommendation. And otherwise, if you reach a threshold, then replace it with blood. And the only thing is, from the ERAS, if it is a daycare surgery and you need early ambulation, it might be a point in giving maybe a little extra fluid, that is over and above the fluid that you normally give for euvolemia. For major invasive surgery, more than 500 ml blood loss, think about placing an arterial catheter so that you can do a goal-directed therapy better. Fluids, again, over even here, do not keep fluids running at a set hour. If you think they're short on fluids, it is possibly better to use supplemental fluid boluses instead of running infusion. And the dynamic hemodynamic parameters are much better uh, to guide you on this, whether it is systolic blood pressure variations or a pulse pressure variations or a variations in stroke volume if you're using a cardiac output monitor. This is, I think, a separate issue in its altogether, but these are things you can pick up if the patient has been mechanically ventilated at a decent tidal volume of above 8 ml per kg. If you find this systolic pressure variations happening, that means they are fluid deficient and they would be responsive to fluid just by following the Frank-Starling curve. And if you don't find the SPV or the PPV, they are not in the fluid responsive zone. Hypovolemia, hypervolemia are both bad, and perioperative tissue edema more often than not is because of retention of fluid administered during surgeries. And the normal physiological parameters that we do, the static parameters like blood pressure, heart rate, CVP, UOP, even if they are monitored continuously during surgery, will not pick up tissue perfusion always adequately. We'll spend some time on this. I know we are getting late, but about temperature control, and it is of huge importance. Core body temperature needs to be monitored, especially if you are doing a surgery which is going to last you more than an hour, and definitely if it is going to last you more than an hour and a half. Your target temperature of esophageal or the nasopharyngeal site has to be above 35.5. And it is here that this graph tells you that there is a steep fall in the first hour. There is this fall, unless you have a mechanism to correct it, will keep falling until it plateaus after 3 hours. And why does the first fall happen? The first initial rapid decrease in core temperature results from a core to peripheral redistribution of body heat. And this is because of the anesthesia that you provide. And this is because of the impairment of the central thermoregulatory control, which causes the vasodilatation. And this is not by the peripheral effect. It is a central effect. And there is, I don't think, any way that you can possibly do anything about it. This is bound to happen. The next one, the slow linear reduction, where the core temperature falls, and it's because the loss is exceeding the production. And this is something that you can work on during anesthetic. And we'll see that you're trying to go there. Finally, you get a core temperature that stabilizes and virtually remains unchanged. And this plateau phase may be a passive thermal steady state, wherein sufficient hypothermia regulates or triggers the thermoregulatory vasoconstriction. So you have this the SVR goes up, there's a vasoconstriction, and the temperature doesn't fall anymore. So this is the plateau phase. What you can work in is this second phase, wherein you lose temperature by evaporative mechanisms, by radiation, by convection and conduction. And all your strategies will be to prevent this. And we'll take you through this, because the consequences of hypothermia are bad, because all your cellular functions are temperature dependent, and mild hypothermia, that is a change in 1 or 2 degrees centigrade, can create adverse consequences. And I'll just take you through this. I think this is a busy slide which I've split it up. What are the consequences and what has the difference in the temperatures and the difference between a normothermic and a hypothermic patients as to outcomes. If you look at surgical wound infection, duration of hospitalization, things like cardiovascular problems like ventricular ectopics, protein loss, all of them statistically significant, worse in the hypothermic group. If you're just looking at our drugs, duration of action of vecuronium, atracurium, propofol, all these will be higher or greater if the persons are hypothermic. A significant difference between 28 minutes to 62 minutes, between 44 minutes to 68 minutes. And outcome, post-anesthetic recovery, you'll find that they are doing bad. And even about, you see things like changes in plasma, norepinephrine, thermal discomfort, people who are hypothermic actually do worse than who are normothermic. And this forest plot brings it out very, very clearly that it is hugely, hugely beneficial to keep these patients in the normothermic zone. Why does this happen? Hypothermia and wound infection. The key issue is with the reduced access of the key immune cells and the reduced motility of the key immune cells, the macrophages. And this leads to worse wound infection rates, worse surgical site infections. Shivering, does it happen intraoperatively? You'll find that it does not happen intraoperatively. The threshold for shivering, as we figured out, is lower than 1 degree, lower than the vasoconstriction threshold. Remember, that was the plateau. And core temperature, therefore, during anesthesia would not decrease by this 1 degree centigrade beyond this vasoconstriction threshold, and which is why intraoperative shivering is rare. And remember, shivering is a thermoregulatory defense mechanism, and general anesthetics obtends this thermoregulatory defenses by its central action. So you will not find shivering happening intraoperatively. Shivering is a post-operative phenomena, and once the anesthesia is worn off, and it prevents this activation of thermoregulatory defenses, and you'll find that shivering, but it has to be avoided, which is why you need to have a good method of prevention and management of hypothermia, because it will develop in all your surgical patients. Even definitely in your unwarmed, and even in the pre-warmed, some of them it will happen. The core temperature will fall in the first hour, and it will further fall unless you have taken measures to do something about it. The first hour, as I said, during GA, it is the central mechanism wherein it is shut off, and that causes vasodilatation, and that causes the shift. So your perioperative warming strategies are pre-warming, get them warm before they come into the OR, passive insulation, devices that actively warm the skin surface, heating the IV fluids or bloods, warming your inspired gas. And this is something that some people are doing it in some places, endovascular systems that directly exchange heat with the circulating blood. The pre-warming can be beneficial, and this forest plot tells you that. Insulation, a single layer or a double layer can be beneficial, and it depends. It's the layers of the air that acts as the barrier, which can, so you can prevent cooling by around 30% with single layer, by 50% if you are using 2 layers. Active warming devices like your forced air warming can also be beneficial, and it depends upon what position they're in as to where you want to use it. Fluid warming, it may not increase the temperature, but it definitely has a role to play in seeing that they do not lose temperature. Because you see, if they are giving around a liter of fluid in an hour, it will drop the temperature by around 0.25 degrees centigrades in a 70 kg. So if you have warmed it up, it will it will prevent this. This is also true about blood warming. Respiratory gas warming, I know that the heat capacity of air is low, and the heat of vaporization that is required to humidify dry gases is low compared with the metabolic rate. And so your warm air will not heat up the patient, but it can help you in preventing the evaporative heat losses. So from temperature, let's come to perioperative glycemic control. I think this is a separate issue altogether. The target blood sugar levels, diabetic, non-diabetic, both is 140 to 200. I think this is something which will finally take us a little time, which is the multimodal antiemitic prophylaxis. And all patients should be given antiemetics. We know that people used to kind of recommend that you do it on a selective risk-based, but the ERAS will tell you give it for all and give a combination of dexamethasone and ondansetron to all your patients. And the selective one was based upon this, the multimodal, which was antiemetic prophylaxis for high-risk patients, given the score given by AFL, where you are looking at 4 criteria, and if they have a score of 2 and more, then you have a higher risk of PONB, which is 40% and higher, which makes them at higher risk. Then you possibly add the third antiemetic. We don't have access to transdermal scopolamine, but I am quite fond of IV haloperidol. If you're monitoring and you're giving with sense, clinical acumen, it gives you good results. I think this is something as to how antiemetics do it better for those who have a higher risk. If you look at this, somebody who has a PONV risk of 80%, our antiemetics are better than those who have a PONV risk of 10%, maybe just one criteria. So if you're looking at a female non-smoker with a history of motion sickness who requires post-operative opioids, just giving a shot of an ondansetron reduces the risk by 20%. So it goes down from 80% to 60%. Whereas if you have a male who is a smoker without motion sickness and who would not need post-op opioids, this same ondansetron would bring down the risk from 10% to only 7.5%. So it works better when the risk is higher. So that is just I put it. So antiemetics, they are additive rather than synergistic, and I think this we went through that Tiva and propofol can be good, but inhalation with an antiemetic is has the same effect. Rescue antiemetics, you have to use a different class than what you have already given for prophylactic, and this is something that is new that I came through, is that if it's because of opioid, even naloxone can be good to prevent this post-operative nausea and vomiting. This is from the Cochrane database as to what can be used at what point of time. It's a busy slide. Go through the Cochrane database, and if you look at it, that once the patient has vomiting, then the go-to drug, especially for the rescue antiemetic, one of the best go-to drug is metoclopramide. And you'll find out from all this that the CI for metoclopramide is possibly the highest. And especially if you have already used up dexamethasone and acetron, then and the person is vomiting in the postoperative, for the rescue, that is a drug that you can go to. Pain prophylaxis, again, multimodal management. It has to be patient-specific, procedure-specific. It's a balanced modality. Depending upon what is the type of surgery, can you manage it with the regional or local, then that is where you go for, and then figure out a choice. The ERAS strongly recommends trying to go out of narcotics and look at acetaminophen and a COX-2. And it is about acetaminophen. pre-op, intra-op, and finally an NSAID like ketorolac at the end of surgery. Local infiltration has become very, very important. And where do you give it, especially if it's an abdominal wound? I think during our residency we learned it. You can give it subcutaneously, just below the skin. What we now know is, not knowing the anatomy a little better, that if you actually need to give it, you need to give it at the pre-peritoneal level, or if you want to go more towards the central neuroaxis, go towards the interfascial pain blocks, a transversus abdominis, or a quadratus lumborum. Can we use opioids? Yes, you still can use it, because I think they are good in what they do, is reducing pain. But think about other adjunct agents, things like dexamethasone. If you have already used it for antiemetic, it will serve you some good purpose. And there is still a role of ketamine, and ERAS is happy to have patients getting 25 to 50 milligrams ketamine. Post-operative is management of pain, management of nausea and vomiting, and observation of the cardiovascular problems, and looking at and dealing with them. What about outcomes? Yes, if you, especially colorectal surgeries, especially gynecology, where the maximum data is from, it has reduced hospital length, stay, and morbidity, reduced post-operative pain, it has got faster recovery, and it's, I think, economically beneficial than this traditional care. Does it have a role to play in the COVID-19 scenario? I think it has, especially after the low acuity surgeries have resumed. There is nothing that I could find on their official website, but they have made these statements that patients who do undergo elective surgery, it is now more important than ever before to implement ERAS pathways, given the increased importance of avoiding complications, intensive care admissions, and to have patients in a condition to leave the hospital as soon as possible. These are certain publications that have come out during the pandemic situation, which has shown that, yes, we might go to it, because it can give you faster recovery, faster discharge, focus resources towards those who are in need, especially when you might have a problem with hospital beds. The concluding remarks is, this is the flowchart for ERAS. If see, this is about pre-admission, pre-operative, intraoperative, and the post-operative period. And we used to think traditionally that does anesthesia have a huge role to play in the ultimate outcome of patients? And I think ERAS has made it pretty clear that a lot of, if you find it, a huge lot of things are about anesthesia, whether it is about optimization in the preoperative period, whether it is about this preoperative carbohydrate drinks, reduced NPO, PONB prophylaxis, regional analgesia, opioid sparing, balanced fluids, temperature control, all this along with a multimodal opioid sparing analgesia in the post-operative period can improve outcomes significantly. So it is not a huge change from the traditional care, but it improves clinical outcomes and it has a clinical economic value. What it has focused and what it has changed over the last 10-15 years is how we are looking at muscle relaxants, how we are looking at opioids, and how we are dealing with pre-medication, and how this can influence long-term outcomes, and how we anesthesiologists definitely do play a huge role, and it's up to us to take that responsibility by this judicious use of antiemetics, analgesics in the perioperative period to improve the outcomes. Thank you. And I know it has been a very long and an elaborate one, but I think that is what I could get to, so that it becomes kind of beneficial for students, and it helps you to know that it becomes as a kind of a template for whatever you are faced with. Can we open the session for question and answers?
I think Vibhu Kollani ma'am has joined. Ma'am, can you hear us?
Yeah, a very good session, and both of you spoke too well. I can everything was very. There is no question, but I only want to ask you about nitrous oxide. For whereas you are recommending nitrous oxide, but in cases of neurosurgery, whether we will go for.
I think, yeah,
Hello.
neurosurgery. Yeah, I can hear you, ma'am. Yeah, neurosurgery, there is this issue about the closed space. Uh, and I looked at certain data about neurosurgery, and if you're not so much bothered about whether about air getting in, or that cranium that you need to close is going to get bigger, uh,
Okay.
there are I think there are units which are still using, which have restarted using nitrous or have continued using nitrous. So it, I think, would be left best to the clinical judgment of the neuroanesthetist to decide
And
whether you
particular
want to use
position, if
nitrous or not. Yeah,
whether it is in a particular position or how much the
yeah,
head is
yeah.
up and all these things.
Correct.
Okay.
Absolutely, ma'am. Absolutely.
And about the respiratory rate, you
Uh,
said that you want to have some amount of carbon dioxide retention for all
uh,
the organs to be perfused a better way. But in case of neurosurgery, again, will be
yeah, I think.
normocapnia
Yeah, I think
ideal for.
I think the general principles should not change for a particular procedure. I think
Okay.
in neurosurgery you do not want carbon dioxide to create vasodilatation. So in a neurosurgical procedure, I think where you're bothered about that, I don't think you will get a rate down to 8. I personally, I do not advocate the rate going down to that low. My go-to rate usually used to be around 14. I am now comfortable around 12. And as long as, because if it's good that I work in a same place, so I know even if the ETCO2 has not been calibrated, I know in which theaters what the ETCO2 collaborates with the PeCO2. So I would be happy as long as my ETCO2s are not going above 45. And then I would possibly work on the rate. So
Yeah.
I would be fine to keep that. But you are right, absolutely. If there is a procedure where you don't want the ETCO2 to go up, I think it's pointless to get your rates down. Absolutely.
So thank you very much. Great job.
Thank you, ma'am.
And
Thank you. I think
yeah.
Anirban
And
has a question about complex carbohydrate drinks. I think it's the complex carbohydrate drinks. I think it's the same thing about the glycemic load that comes with it. Nothing better than that. And certain things like the maltodextrins, where the people have figured out that the gastric emptying time is faster than your normal simple sugars, and that is the reason. I at least don't know of anything else. Dr. Debjani Gupta, hi Debjani Di. Any changes in opiate addition to Duraxil blockade for postoperative pain relief? I think I would have not found out anything about this. The many people would tell you today that it may not be a great idea to use an opiate, but I still would be happy to use opiates along with a local anesthetic, because I think the blockade is better. The duration of blockade is better. But then people would tell you that do you want that huge increase in the duration of blockade? So pros and cons. I think if intuitively, if you want, if you know that the person is going to be discharged earlier, you possibly, and you know that you don't want, say suppose something like a TURP surgery, and you know that what is there going to be huge amount of pain in the post-operative period? If it is the answer is no, then would you think that adding an opiate would be beneficial? I think we look at it in that way. Otherwise, nothing. I think Akash was asking whether the intraop fluid therapy of 3 ml per kg per hour. Yes, it takes into account that there has been clear fluid up to 2 hours. Otherwise, again, if there has been, if the person is not fluid deficient, I don't think there is any point in preloading prior to that. I would answer that way. Yeah, Dr. Devjani Gupta is very comfortable with a respiratory rate of 8 to 10. I think many people are. I know there are quite a few friends of mine who are very happy ventilating at around 8 to 10. Dr. Manik Nimani wants to know whether can we use a loading dose of Maxalf 50 to 60 milligram as a preemptive analgesia for early recovery. Madam, I have no idea, no experience on this. But Maxalf people have used in the preoperative. Yes, I think.
Yes, Dr. Bunny, can you hear us?
Yes. I am asking you one question is that especially in this is the pandemic corona situation, any change in the paraoperative fluid management, especially in the corona patient during the obstetric cases, especially in under regional anesthesia.
I haven't done a huge lot. I have possibly have done a few. If I've gone through the Royal College recommendations, and I've also spoken to a few of my friends like Dr. Bhaskar in Chennai, who has done a lot, plenty. I think their fluid strategy has remained the same, and the anesthesia strategy for COVID patients undergoing C-sections have remained the same. It's just your personal protection equipment that you use have changed. Nothing else that I know of.
Now the patient, some of the patient have come with the respiratory distress. Already the patient have a respiratory distress, and that are so. I think in the same times we can provide the general regional anesthesia, spinal anesthesia, and give the fluid and preload. There is a chance of any more in the pulmonary edema or ARDS in that situation.
And not that I have read of, or not that I have heard about. So their fluid management strategy, because I think most of you would not preload, so the preloading is not there. If there is hypotension, you would use a vasoconstrictor. So I think that strategy remains just the same.
We cannot preload the patient now in COVID patient. We can use only the vasoconstrictor only.
Yeah, absolutely, absolutely. Yeah, absolutely.
And we can also the fluid requirement also someone shortly they recommended especially to reduce to some form because of the we have a if doing the oxygenation. I have done the more 3 or more patient with the respiratory distress and need oxygen requirement is more than 10 liter per minute and saturation is 95, 94 and blood pressure around 100 and by 60 millimeter of mercury during perioperative period. But fluid, after giving the fluid, he is worsen and worsen. So I can restrict the fluid and given only the vasoconstrictor and continuation of
absolutely,
surgery.
Sir. Absolutely. Point taken, sir. Abu wants to know whether it is reasonable to use 100% oxygen when nitrous is contraindicated and air is not available. This is a difficult thing because I don't think you have any choice, isn't it? If you don't have air and you do not want to use nitrous, then you don't have any choice. So be careful about it. But I don't think you have any choice. It's a options choice actually. Not a great idea, but then you don't have choice. Is TPN Gauri Di, thank you for joining us, Gauri Madam. Is TPN routinely recommended for nutritional support? I think it is not routinely recommended unless you can feed the gut, and then that's the only way that you can support nutrition, and that's TPN. How admission on the day of surgery influence areas? I think it is Dr. Nilobruto Ghosh. I would say that the way to go is that it depends upon, again, the PFE, the patient and family education. They should be aware as to what they need to do at home, and once they get in. Fortunately, in our country, this is not a big deal as yet, but it is becoming more and more popular. Uh, it, I think the kind of communication that has to go through, as to, it says it's something like that: before you leave home, take a oral paracetamol and then come in, or take an ondansetron 8 milligram and then come in, are things which can come in the patient family education. Thank you, Shweta, for the comment on 3 to 4 ml per kg. That's a good question from Dr. Shomodipal. Any recommendations in COVID-19 about the use of nitrous oxide and lung function? The moment you mention COVID in this day, there will be people with huge amount of COVID queries. I haven't found anything about nitrous and the COVID. So if you have, please let me know. But intuitively, and going by the pharmacology or the pharmacodynamics, I don't find any reason why you should not be using nitrous, even in a suspect or in a proven positive, unless there is this huge issue with oxygenation. So if you are actually dealing with a patient with SARI who have an issue in their lungs, wherein oxygenation is a huge problem, and these patients then come in for say an emergency surgery, unless they would never ever come for an elective surgery. So otherwise, I don't find any reason not to use nitrous in the general population during the pandemic. But in COVID-19 patients with compromised lung, I don't think you'll be using it. So if you are asking directly, compromised lung function, should I use nitrous? My answer to it is compromised lung, even without COVID-19, would you have used nitrous? The answer would have been no. The answer still remains no. Yes, Debjanidhi. As ever before, in case of a compromised lung, it would be oxygen, maybe a higher concentration of oxygen, and maybe air. But again, if you are able to maintain oxygenation with nitrous on board, I would be happy to have nitrous on board. I think, thank you very much. Jyoti, you can make the concluding remarks and close the session.
I would like to thank Dr. Sengupta and Dr. Ghosh for the lovely session, and I would request all the participants to kindly share your feedback. You will be getting a mail very soon to share your feedbacks, and you'll be getting an e-certificate of this whole webinar, and within 24 hours you'll be getting a link in which you can also view the recorded version of this whole webinar. So I would like to thank sir, I would like to thank ma'am and everyone who has joined. Good night.
Thank you. Thank you.
Okay,
Bye-bye.
good night, Jayati. Thank you, sir. Good night, sir. Good night, everyone. Bye-bye.
Yeah, good night, everyone.